Good morning, good afternoon, and good evening, wherever you might be. Welcome to the annual scientific workshop EECA INTERACT 2023, and thank you for joining us. I'm Ellen Roskam, the coordinator of the International Geneva Global Health Platform. And with me today are the co-chairs of the workshop, Professors Catherine Hankins of the Amsterdam Institute for Global Health and Development, Anda Kivit-Urtan of Riga State University, and Michelle Kazachkin of the Geneva Graduate Institute. Today, we are bringing together scientists, policymakers, and civil society from the Eastern European and Central Asian region to debate issues of HIV, tuberculosis, hepatitis, and public health. Yearly, the EECA INTERACT workshop highlights research, advances science, builds networks, and strengthens local capacity across the entire EECA region. We'd like to thank our co-organizers for making this event possible, AFEW International, Amsterdam Institute for Global Health and Development, and the Global Health Center at the Geneva Graduate Institute of International and Development Studies, as well as our partner Riga Stradins University. The recording of the event will be available on the website in a couple days at this link, eeca-interact.org. Simultaneous interpretation in Russian is available during our event today if you just click on the world icon at the bottom left of the screen and select the Russian language channel. There will be a small question and answer session towards the end of each panel session, which will be open to the entire audience. Please type your questions or your comments in the chat box, not in the Q&A box. And you can also address any questions or comments directly to an individual speaker in the chat box. Now I'm delighted to introduce the co-chairs of our first session today, Michelle Kazachkin of the Global Health Center, Geneva Graduate Institute of International and Development Studies in Switzerland, and Maksut Kuzanov of Asfendiarov Kazakh National Medical University in Kazakhstan. Maksut, Michelle, the floor is yours.
Thank you, Ellen, and welcome to all participants. Unfortunately, Michelle absent, and he participated in a very important event. Our first session dedicated to the important topic of the impact of the war on Ukraine and beyond Ukraine across the EECA region. Our speakers today, this session, Timur Abdullayev, board member of TB People Global, representative of human rights and sustainability of the national HIV and TB responses in EECA at UNDP, Uzbekistan. Olga Gvozdetska, via a pre-recorded video, acting deputy general director at the Public Health Center of the Ministry of Health of the Ukraine. Justina Kowalska, senior consultant at the Hospital for Infectious Diseases in Warsaw and professor of medicine at the Department of Adult Infectious Diseases of Medical University of Warsaw, Poland. You can find their full bio on the event webpage. Please type your questions on the chat box and they will be answered at the end of the session. It's now my pleasure to invite our first speaker, Timur Abdullayev, who will speak on the social, political, and economic impact of the war on the whole region. Timur, the floor is yours. Please.
Thank you very much, and probably I will switch to the Russian channel, given that we have quite a number of Russian-speaking participants, so it will probably be more convenient.
Yes.
So I'm switching to Russian. Окей, итак, я надеваю наушник и начинаю вам рассказывать, вещать. В первую очередь хотел бы сказать то, что, наверное, всем понятно, что самое большое последствие войны, оно для Украины. Вот, и буквально недавно были опубликованы последние данные в плане разрушений медицинских учреждений в Украине в результате российской агрессии. И такие цифры, ну, достаточно ужасающие. То есть 1468 медицинских учреждений были затронуты, 193 было полностью уничтожено. Это, ну, это очень большие цифры на самом деле. Вот. И кроме этого было уничтожено 253 машины скорой помощи, 103 было повреждено, 125 захвачено. Почему я об этом говорю? Потому что понятно, что все это не может не повлиять на доступность медицинской помощи в самой Украине. И более того, если учесть, что война привела к тому, что, естественно, большое количество медицинских работников, они были фактически переброшены на фронт для того, чтобы оказывать медицинскую помощь военнослужащим. Это тоже негативно сказалось на гражданской службе здравоохранения. Вот. И понятно, что такой ущерб, он очень сильно, на самом деле, сказался на доступности помощи, на качестве медицинской помощи. Но нужно также иметь в виду, что из Украины за последние 2 года отмечался самый большой отток, миграция, отток беженцев, отток вынужденных мигрантов. И, в общем-то, уже понятно, что вот этот вот кризис украинских беженцев, он уже был признан самым большим кризисом беженцев и беженок и крупнейшим миграционным кризисом в мире в 21 веке. Ну, чтобы вы понимали, да, масштабы, с момента начала войны прошло меньше 2 лет. За это время мигрировало в общей сложности что-то порядка, если я не ошибаюсь, на 13 декабря, если не ошибаюсь, где-то 8 миллионов человек в соседние страны. И это, в общем-то, количество, оно очень большое, и нужно иметь в виду, что помимо этого было также большое количество переселенцев и внутри Украины, но в целом вот как бы цифры количества людей, которые вынуждены были покинуть свои дома, в общем-то, ну, если я не ошибаюсь, оценивается где-то в порядка 20 миллионов человек. Это, в общем-то, количество, ну, где-то по разным оценкам от половины до трети общего количества беженцев и переселенцев, которое вот наблюдалось во время Второй мировой войны за 6 лет Второй мировой войны. То есть понятно, что это ужасающие масштабы. И к чему это все привело, я еще поговорю. Но я также хотел бы отметить и о том, что страна-агрессор, в общем-то, тоже отметилась рекордными потоками миграции. С момента объявления мобилизации из России уехали по разным оценкам от 500 тысяч до 1 миллиона 300 тысяч человек. Ну, понятно, что эти оценки не включают оценки Росстата. Там вообще все, в общем-то, у них цифры такие радужные, что меньше 100 тысяч покинуло Россию. Вот. Но на самом деле те страны, которые стали принимающими странами, они могут засвидетельствовать, что цифры на самом деле гораздо больше. Так вот, к чему привели вот эти вот миграционные потоки? Ну, в первую очередь, понятно, что, и это касается, наверное, даже если мы говорим о регионе, наверное, в первую очередь это за пределами региона. Западная Европа не была готова к такому количеству людей и не была готова к тому количеству людей, живущих с ВИЧ, людей с туберкулезом, людей с гепатитами, которые вдруг оказались у них и нуждаются в медицинской помощи. Скажем, в Польше, в Румынии, в Германии система здравоохранения, она не была готова к такому. Вот. И сейчас в этих странах сами, собственно говоря, сами люди, которые переселились туда, они занимаются тем, что они самоорганизовываются и пытаются решать эти проблемы в плане доступности и диагностики, и лекарств. Вот. Но на самом деле в нашем регионе эти проблемы не менее остро ощущаются. То есть если посмотреть даже на, скажем, страны, которые приняли большое количество переселенцев и беженцев, и иммигрантов, в общем-то, ну, ситуация достаточно напряженная, потому что в большинстве стран бесплатная медицинская помощь, она предусмотрена для граждан. Для того, чтобы иностранные граждане получали медицинскую помощь, ну, для этого требуется менять в том числе и законодательство. Для этого нужна политическая воля, для этого нужны ресурсы. Где эти ресурсы брать? Никто не планировал, что будет такой наплыв беженцев, никто к этому не был готов. И понятно, что, в общем-то, пришлось, скажем так, перегруппировываться очень сильно с нашим странам. Когда я говорю про наши страны, я имею в виду наш регион, но вот говоря об Узбекистане, у нас также к нам приехало определенное количество переселенцев из Украины, большое количество переселенцев из России. Вот. И, в общем-то, конечно, здесь на месте пришлось очень так думать, находить какие-то пути, изыскивать возможности для того, чтобы тем, кто, скажем, люди, живущие с ВИЧ, среди этих переселенцев, среди этих мигрантов, люди с другими заболеваниями, чтобы они могли получить качественную медицинскую помощь и при этом ту помощь, которую они могли бы себе, в общем-то, позволить чисто финансово. Ну и, наверное, помимо непосредственно такой нагрузки на систему здравоохранения, нужно также понимать, что вот эти миграционные процессы, они привели и к другим последствиям. Вот. В первую очередь, я думаю, что те, кто, скажем так, ну вот я думаю, доктор Максут, наверное, тоже, поскольку Казахстан принял большое количество переселенцев, может согласиться, насколько выросли цены. Цены на все выросли, начиная с жилья, начиная с аренды жилья. После этого начала подтягиваться цена недвижимости на покупку-продажу. Все это на самом деле как бы имело достаточно негативный такой момент. То есть вот эти вот всплески, они не полезны для экономики, да, то есть мы очень много слышали, знаете, вот в русскоговорящем сегменте я встречал такое, что вот русские приехали с деньгами поднимать экономику, создавать рабочие места. Это на самом деле чушь, потому что большинство стран, которые приняли переселенцев, столкнулись с вот этим вот всплеском миграции, который потом ушел на самом деле в минус. То есть люди приехали, посмотрели, оказалось, что все не так радужно и продолжили движение дальше. То же самое касалось, например, и тех переселенцев, которые оказались в Европе. Когда они приехали, скажем, в ту же самую Польшу, они поняли, что, в общем-то, хочется двигаться дальше. И те, кто приезжали в Узбекистан, тоже поняли, что Узбекистан это, собственно, не так радужно, как они себе представляли, и что на самом деле не нужно путать туризм с эмиграцией. Вот. И в итоге получается, что вот этот вот сначала наплыв, а потом и отплыв, скажем, мигрантов, он здорово так шатанул экономику наших стран. И это, конечно, ну, негативно сказывается на бюджете. А почему я говорю о бюджете? Потому что за счет средств государственного бюджета закупаются препараты. И когда такие происходят стрессы, то нужно очень постараться, чтобы доказать, что нужно на самом деле расширять программы лечения, нужно приобретать, нужно успевать, скажем так, идти в ногу с наукой, чтобы появлялись новые препараты, новые диагностические средства. То есть все это означает, что адвокация должна продолжаться, и причем продолжаться с новыми силами. Но при этом я должен заметить, что действительно некоторым странам повезло, они получили шикарных активистов. Я, например, знаю то, что очень много классных активистов переселилось в Кыргызстан. Вот, и Кыргызстану я искренне завидую, потому что сейчас у них там сидит, например, команда ITPC, и это, я считаю, им повезло. Я бы их с удовольствием в Узбекистан бы перетянул, например. Вот. Но на самом деле все это, конечно, не так смешно. Это никакой не повод для радости. Это все очень, на самом деле, грустно. Также начинаются какие-то такие социальные процессы, трения, немножко так растет социальная напряженность. В этом плане, в каком-то смысле, это звучит идиотски на самом деле, но помогло то, что происходит на Ближнем Востоке. То есть вот арабо-израильский конфликт, он поменял фокус внимания, потому что если до этого шли баталии между теми, кто за Россию, и теми, кто за Украину, то сейчас вдруг как-то началось все, вот те, кто за Израиль, и те, кто за Палестину. И это немножко сняло напряженность вот именно вот в этом отношении. Хотя понятно, что это не совсем так. На самом деле социальная напряженность, может, поменяла несколько вот этот вот угол, но ракурс, но на самом деле она никак не влияет позитивно на ментальное здоровье, на настроение в обществе. Вот. В принципе, я, наверное, могу закончить, но я хочу сказать то, что все это так или иначе оно сказывается на политических курсах наших стран, на политической обстановке, и все это, в общем-то, очень сложно, и я думаю, что мы еще долгие годы будем видеть последствия этой войны. Я не говорю про Украину, которой предстоит еще долго биться за то, чтобы победить. Уж извините меня, я болею за народ Украины, я всегда сопереживаю тем, кому приходится защищаться. И поэтому я надеюсь, что война в ближайшем времени закончится, и закончится победой Украины. Слава Украине. До свидания.
Спасибо. Спасибо. Thank you, Timur. Now it's my pleasure to invite our second speaker, Olga Gvozdetska, who will speak on the resilience of Ukraine in the time of war. Unfortunately, Olga could not present with us today, but she has generously provided us a recording which will be played now.
Good morning, dear colleagues, dear guests. It's a big pleasure for me to have a possibility to be a part of this meeting and to join you even virtually. Over the decades of the fight against HIV, TB, and hepatitis, Ukraine has made considerable progress. As of the beginning of the 2022, HIV, TB, hepatitis, and OST services were provided considering modern international strategies, according to clinical protocols and healthcare standards based on evidence-based medicines. But since February 2022, when the full-scale invasion of the Russian Federation started, Ukraine has been experiencing a tremendous humanitarian crisis due to the permanent hostilities of the well-known aggressor. According to the latest available data, almost 1,700 healthcare facilities were damaged and around 200 were destroyed in Ukraine. Civilian casualties continue to rise as of December 2023, almost 10,000 civilians were killed. A Russian invasion of Ukraine continues to cause daily destruction of civilian infrastructure, death and suffering, and generate humanitarian needs. All these factors, compounded by the persistent state of insecurity, have triggered an immense wave of displacement and migration, both within and beyond Ukrainian borders, and further disruption of health services, including those for HIV, TB, hepatitis, and OST. Recognizing the situation urgency, the country swiftly mobilized all available resources to ensure the continuity and resilience of these vital healthcare services. In response to the pressing needs, strategic approaches were developed, recommendations and algorithms were developed and shared, so patients who have moved temporarily could receive medicines as a point of care for example, where they were actually staying rather than at the place of the registration. To cover the funding gap, as the state budget could not longer cover the procurement of medicines and services, as it has been in previous years, a series of negotiations were held with donors to attract additional funding, which prevent interruption of treatment and access to services. Through close and coordinated collaboration with donors, partners, civil society organizations, volunteers organizations, several immediate managerial decisions were implemented to restore the supply chain and ensure a continuity of treatment for thousands of patients during marital law. The constant displacement of people, power outages, destruction of facilities, and other consequences of the invasion made monitoring and information storage more important than ever. An algorithm for collecting and exchanging information for facilities that disconnected from medical informational system due to occupation, telecommunication problems, internet, phone connection, or experience power failures was developed to ensure quality data exchange and storage. Amidst the terrible challenges of war, we have not only stood resilient, but also used these advances as a catalytic for innovation and progress. The shadows of war have not eclipsed our spirit. Instead, they've ignited a fire within us to explore new horizons and embrace novel opportunities. While our defenders are protecting us on the front line, we need to ensure a reliable backline and do our job. Fight with no less tricky enemies: HIV, TB, and hepatitis. In the face of adversity, our collective dedication to combating HIV has not wavered. We have strived to ensure that even during war, people living with HIV continue to receive uninterrupted access to life-saving treatment and care. Testing, RV treatment, HIV prevention, care and support services continue to be provided in every region, and patients can receive RT in the place of their actual state. Also, Ukraine has become one of the 5 PEPFAR partners countries prioritized for cabotegravir long-acting delivery in 2023. The advantage of injectable PrEP is that it makes it possible to simplify the drug regimen, as oral PrEP requires daily or as needed dosing. The patients may have difficulty with this. Test and start strategy was implemented. Over 75% of people started RT within 7 days of diagnosis. Significant progress was also made in the area of tuberculosis. In 2023, the law of Ukraine on overcoming tuberculosis in Ukraine was adopted. This law defines the legal, organizational, financial framework for activities aimed at overcoming tuberculosis, ensuring medical care for people with tuberculosis and equal access to it. In addition to regulatory framework for TB control was updated in line with EU standards as the latest international recommendations. Despite the war, we managed to achieve the TB medical and social support services for people with TB will be available from 2023 budget Innovative approaches to the detection, diagnostics, and prevention of tuberculosis and latent tuberculosis infection have been introduced. Tests to determine the release of gamma interferon quantiferon tests and short-term regimens for TB infection based on the innovative drug rifampicin. Despite the advertisement, our country faced that OST program continues to make significant steps in combating opioid addiction and providing vital support to those in need. Ukraine has received the most advanced OST drug, the extended release form of buprenorphine Buvidal as humanitarian aid. The drug requires 1 injection per month for a patient in state of daily medication. As of end of November 2023, 215 patients in 10 regions of the country were involved in treatment. According to the interim results of the study, about a set of patients completed completed treatment and switched to the tabled form of therapy. Some patients were able to complete OST treatment. The implementation of a pilot project about video supervision for taking OST medications was started and was successfully implemented. One of the key achievements of the introduction of electronic prescriptions for narcotic drugs that allow us to receive prescription remotely. In 2022, the procurement of rapid tests for diagnostics of hepatitis began at the expense of the state budget. In 2023, almost 1.5 million rapid tests were delivered to the regions and distributed to more than 1,200 primary, secondary, and tertiary healthcare facilities. Testing with rapid test for hepatitis B is included in the list of services provided by family doctors and in other 11 packages of the medical guarantee program funded by the National Health Service of Ukraine. One of the packages was included in the list in May 2023 and covers the needs of persons during the Military Medication Commission, including screening for viral hepatitis markers. Public Health Center, together with the Coalition of Global Hepatitis Elimination, has developed a national profile on viral hepatitis elimination. This resource allows us understand the current state of the viral hepatitis epidemic in Ukraine. The profile is published on the Coalition for Global Health Elimination website. One of the most important common achievements is that despite the war and its consequences, no single program has stopped. Medicines continue to be procured and services continue to be provided and available in all government-controlled regions of Ukraine. The country has prepared a comprehensive funding request to the Global Fund for 2024-2026 with participation of key stakeholders and representatives of civil society. The comprehensive approach ensures that the funding request not only addressed the immediate requirements, but also embraced a holistic view encompassing diverse perspectives and insights from various stakeholders. With unwavering determination, we remain steadfast in following a shared vision for a better tomorrow. We build plans, we set goals, and we continue to do our job daily. In the way of the challenges that defined 2022-2023 emerged not just a continuation, but as a key chapter where resilience transformed into strength. While the previous year demands swift responses and adaptive measures to navigate unprecedented challenges, 2023 became the stage where these responses evolved into a foundation for growth, for fortitude. We used each challenge and barrier we encountered as an opportunity for learning and adaptation. In the face of adversity, our commitments remain unwavering. We stand resolute in our fight, believing in the triumph over the war challenges and the relentless battles against HIV, tuberculosis, and hepatitis. Together, hand in hand, we persist in our pursuit of victory, fueled by the steadfast belief that our resilience, unity, and determination will lead us to the brighter horizon we all strive for. Thank you a lot.
Maksut, the floor is yours. Thank you.
Yes. Thank you, Olga, for your very impressive video message. And we very impressed how Minister of Health, how all society organized necessary care for this group of patients, and especially even mental problems. And of course, next our speakers, Justina Kowalska will speak on the perspective from the largest Ukrainian refugee hosting country, Poland. Justina, the floor is yours, please.
Good morning, or good evening, or good afternoon. It's my pleasure to be here and present so many efforts we had in Poland towards solving the unexpected. I understand I'm expected to share my presentation, right?
Correct. You can use the share button in the lower part of the video.
I'll try to find out.
Right, we can see it. You just need to put it in the slide share. Perfect, great.
Okay, so once we can see it, once again, thank you for inviting me, and I have no conflict of interest to declare. It has been already mentioned that we have faced something that has not yet been experienced on such a scale, and I'm showing now the very first days in February 22 and March, where a massive displacement happened and people in panic were crossing the borders. The borders were all immediately open, and a great thank you to custom officers through and administration through both of the borders that they were willing and available to support such a massive migration. So within the first 8 months of this migration, we had 1.2 million refugees registered for public insurance in Poland. This is to respond to earlier Timur presentation and the worrying, always us worrying about availability of care and support for migrants in many Central and Eastern European countries, including Poland. Governments decided to provide immediate universal health insurance. So all these registered migrants, whoever wanted to obtain a central registration number, same as Polish people have, could use all the services with no restraint. We, at that time, within the first 8 months, we also saw that the migration of people living with HIV was quite intense. We registered 2,600, almost 50 Ukrainian migrants living with HIV. And this was increase of 15% in our total national cohort. Nowadays, we have around 3.5 Ukrainian migrants living with HIV registered in our care, and they receive exactly the same standards and care access as Polish citizens. You can see here on the photos the patient who we admitted to the hospital, and all her belongings were in these 2 bags. That's how people were traveling in panic, not really ready for winter weather, so we had a lot of infections and frost bites. In the beginning, we also were looking into the passports for having a specific stamp, but it was very quickly we were aware that people were not even carrying any documents. So we had to approach this somehow, and we changed the system into having centers providing them with the administrative work. I would like to thank all the administrative forces in Poland. Those were hours of work overnight. We opened a national stadium to be able to provide the registration to all the refugees who want to register in Poland. And it was a massive collaboration between people who were just admitting migrants to their private homes and a governmental response and administrative workers. Here you can also see on the photo, this is a central station in Warsaw. So this was the hub for managing people coming from Ukraine to being allocated to different care access. Some of them were just transferring to go to, for example, Berlin and Poland for first months, I think even a year of migration, provided absolutely free of charge transportation to any possible destination in Europe. So people could go to Rome, Milan, Spain using our train or buses free of charge. Of course, the needs were very difficult to be unpredicted, and this is just my personal experience. I was not imagining doing such a things at the same time, so we were sending antiretrovirals that we could gather here, that we also received from German colleagues, other HIV associations, to help those who were locked outside of their houses, but in other countries. For example, we were sending also individual packages for people who requested from Bulgaria, different things that dynamically changed, because the dynamic to adapt to this situation was luckily very good and adherent and relevant. But I also became a ciocia, which is also in Russian ciocia, and in English aunt, because my colleague stayed with me together with her son, and I wouldn't be able to imagine that, but yes, when you have a mother and a child, you need to find someone who would be the closest representative of a family. So in case she gets sick or stuck in a traffic or whatever happens, there need to be someone who is affiliated to be able to legally take the child into care, and we had to immediately arrange that, and also to acknowledge that all the schools opened to Ukrainian children immediately. And since we have been hosting Ukrainian migrants, mainly economical migration, for many years, we already before 2014 had 1 million Ukrainian people working in Poland. It is normal for children in Polish schools to have Ukrainian colleagues. So there was luckily for children, there was no abrupt and difficult timing. Another thing that we were trying to help with was finding a combat equipment that would help in for medical purposes, of course. It was very difficult, but we managed, hopefully, to help many wounded people. Also, I would like to acknowledge almost over 250 medical staff who died or was seriously injured, trying to help the people and patients in Ukraine. These Ukrainian doctors, nurses, and medics are heroes. That is amazing that Ukraine, as presented by Mr. Gwozdecka, where they are still able to provide high standard of care for many diseases, especially infectious diseases. We were, of course, also unaware what is the scale of HIV epidemic that we might be facing. There were 3 different estimates provided by ECDC. Luckily, the lower scenario occurred to be true, so the number of HIV positive people is more likely to be the one of those registered in care, which is 130,000 on antiretroviral treatment, plus minus a few more thousands, but it's not 300,000 or something. At least we are not observing it in Poland. Also, yes, we still have late diagnosis, and we are very careful to test all Ukrainian refugees in order to detect new cases. What is the background for HIV epidemic in Poland? You can see here the estimates. Those are not estimates, I'm sorry. Those are a real world data coming from National Health Fund. So those are the numbers of Polish people who are in care. And you can see that since last 10 years, we have a steady increase of around 7% in our new cases. All of these patients receive immediately antiretroviral treatment, which means that we are still doing very poor with early HIV detection, and we are not really doing well with prophylaxis. There is no access to PrEP or PEP free of charge in Poland for HIV exposed people. Having this poor background, still, as I already acknowledged, there has been a huge willingness from governmental support to provide us with a right and convenient environment to work. So me as a doctor, I had no worries regarding whether it's a Ukrainian refugee, non-refugee, or Polish patient. It was all the same. All was immediately the solution was there in electronical system. I could just work with these people, a huge relief. And we have done the Euro Guidelines in Central and Eastern Europe network group, which includes around 100 doctors. It's an association of 100 doctors from Central Eastern Europe region. We are all very active. And we have immediately reviewed the access to care that work has been presented at AIDS conference in Montreal, and it's now published in AIDS Journal. We requested all 21 countries on different levels of access to care for HIV. For refugees living with HIV. You can see Belarus, Hungary, Poland, Republic of Moldova, Romania, and Slovakia. Those were the countries who received the first wave. And we can see that 86% of these countries had same-day doctor consultation and antiretroviral disposal. So there was no delaying in accessing care. And the most important is that was for people who were just in transition to some other location. They also received treatment irrespective of whether they would like to register for a longer care in this center or not. And 77% of these received at least 30-day drug supply. This was very difficult times because, as you know, procurement is quarterly and half-yearly, so we can only give what we have. We needed to be very careful in order not to provide not to shrink the medication for people who already receive it from our own national cohorts. So it also required some of strategic planning and logistics. We luckily managed that. But as provided here, 36% of patients had to be switched from their current regimen, TLD, so tenofovir, lamivudine, dolutegravir, which is a leading major first-line treatment by WHO guidelines, is not as co-formulated in one pill is not available in EU, so that there was some logistics as well. In the beginning, we received donation from through the WHO arrangements, but now the donation is gone, so we have to more and more switch patients to a different regimens. What is very important is that 81% of the centers indicated that it affected, that they were afraid that it would affect the local HIV care standards, because believe it or not, but we were still the same number of doctors, nurses, cabinets, there was, and working hours. So within the same hour of work, I had to double my workload. I had to admit twice as many patients. And it was challenging, it still is challenging. In order to barriers that were identified, the one that I showed, no medical documentation was the leading one, and the language remains a huge barrier for countries like Romania, for example, where they cannot intuitively understand Ukrainian the way we can. So we also provided a project that was trying to insight into migration patterns and whether we sustain linking patients to care, and we sustain the effectiveness of CART to make sure that to understand the size of potential impact on continuum of on 90-90-90 regionally. So that has also been mentioned by Dr. Gwozdecka, that there has been a standardized protocol developed by several key stakeholders, including EECA network. And we developed the forms that the patient could sign, and we, in the name of patients, were sending to the public health center in Ukraine. And in return, we were receiving data on a predefined, as you can see, Annex 4, predefined form. So you can see how the form looks like here. It's provides all the necessary information, including all the history of antiretroviral treatment, which is very important for us first, and ongoing CD4 and viral load measures. And if there was a case of other disease like pulmonary or TB or hepatitis, it is also in the form. Looking into these results, between these 2 times, March and April next year, we were able to, within the project, it's just the numbers from the project. Of course, the total number of patients in our care is much larger. 98.7% of these people were able to be linked, and we received information, so we have tested the tool that it really works. It's a great collaboration with the Ukrainian Public Health Center and provides us substantial help to patients and to our knowledge about them. Please look that 64% of these patients had a Polish social security number, so they are eligible for any help that Polish people are eligible. That's very helpful, as I already said. An interesting thing was to observe how the population of refugees coming to Poland changed within the cohort we observed. At the pilot stage, very early, we had mainly women coming to Poland, but now within 12 months, it has changed to 63% being women. We see more and more people who are living with HIV coming to Poland because they are they have exception from martial law, so even men can come as long as they have chronic disease. I've mentioned switching. So here you can see how do we switch our patients on the example of this project. And we tried, as I said, to remain the first regimen, the regimen people were at, but we are shifting to bictegravir-based regimen. This is more accessible. The dolutegravir-based regimens, they need to be changed from 1 to 2 tablets. So it depends on what the patient agrees to do. This is another project on a larger group of patients, but this confirms exactly the same, that we mainly switch to integrase inhibitor-based therapy and try to switch the middle option, so bictegravir, because it's a 1 pill and it contains tenofovir alafenamide, so it would be a preferable antiretroviral treatment for our patients, and that's how we treat also Ukrainian refugees. We looked into the last available in Ukraine to first available in Poland CD4 count and viral load, and I just not going into details. I can show you that 7.8% loss in undetectability was observed. I think taking into account the situation, this is a great achievement. I'm sure we will be able to rebuild this 8% loss very quickly, and that we have faced it in a very effective way to be able to sustain effective antiretroviral treatment and access to it. But of course, we need to see it as a bigger picture, so not only among those who were tested. So if you include those who were not yet tested as a failing, this is a slightly larger number. So we need to make sure people not only that people are linked to HIV care. And coming to hepatitis, this is a subject to worry about. In our project, we have had 3 groups of patients, those who has never been tested for hepatitis either in Ukraine, and we tested them in Poland for the first time, those who were tested in Ukraine and they were positive, and those who were tested in Ukraine and they were negative. And not going into details, you will have these slides available in recording, just to highlight that of those who we tested, 7.6% had confirmed detectable hepatitis C RNA, meaning they were actively infected and in need for antiviral treatment. And to reply to Timur's worries about access, there is absolutely no restraint or barrier in accessing DAA treatment for hepatitis in Poland. We already treated half of the patients who were revealed as active. We can do it for a larger population as well, because luckily we have already treated most of active hepatitis C infections in Poland. So those are only recurrent infections that we do need to treat now. So there is a large space for treating people from other countries. But also, interestingly, some people returned back to Ukraine to get their hepatitis C treatment there. They consider it just faster, easier. They wanted to talk to their doctors to make sure that this is something that they should do. I mentioned that some people were detected as a late diagnosis in Poland. So this new diagnosis, mainly those are late diagnoses, and you can see here the characteristics. And of course, large proportion of these patients, fewer cases, as I say, new HIV infection is rather very rare as comparing to people who are migrating with already recognized and treated HIV infection. But those are the cases that require help and support from peer-to-peer. That's obvious because there has been an issue and social barriers for the reason for which people were diagnosed late. This is very often also related to comorbidities, the AIDS-defining events, and you can see that the largest group of these people is heterosexual. I also wanted to acknowledge that even though that there is war and so many problems, Ukrainian team from Public Health Center and Ministry of Health were able to join the recent EACS conference, this European AIDS Clinical Society conference in Warsaw that gathered 3,000 people, and we had a session together and discuss achievements and challenges, what to do next, how to sustain the successes we achieved and overcome barriers. So I would like to acknowledge all the people who are working with me on the project to understand the migration patterns. And also you can see at the very bottom Mrs. Olga Gwozdecka, who already gave us a wonderful presentation. She gave many interviews to international journalists, which is very helpful to raise awareness and understanding for the situation. And also on the right-hand side, the team from Ukraine, Olena Samsonova, who is doing all the job in seeking patients' records and contacting with the centers. And I would also like to thank all the Ukrainian doctors with whom I have a direct contact, and they are always happy to talk about patients, to provide with additional information, and also to reassure them that we are doing what would have been done otherwise. Thank you very much indeed.
Thank you, Justina. It's a very important message, and we know how Minister of Health of Poland, Association of Medical Workers, Izba Lekarska, try to help to all Ukrainian refugees in your country. Now we have a little bit of time for questions, and if we won't have time to answer them all, the speakers can type the answers in the chat box even after the session ends. Thank you for the speakers and the audience for the session. Now it's my pleasure to hand over to chair a second session for today to Professor Anda Kirite-Urtane of Riga Strautins University, Department of Public Health and Epidemiology, Latvia, and Stefan Baral of Johns Hopkins Bloomberg School of Public Health. Anda and Stefan, floor is yours. Thank you.
Yeah, thanks very much. We're going to keep actually introductions very short so that our speakers can have time to speak. But I just want to say very briefly, I think we've learned a tremendous amount, and we just heard this very powerful presentation on the importance of treatment as a life-saving measure, even in very difficult contexts. But we also really recognize that the strategy forward is a mix of both prevention and treatment, particularly the introduction of existing forms of PrEP and new forms of PrEP, as we've heard, long-acting forms of PrEP. So our primary speaker, Stella Bival, who's the unit lead at the Joint Infectious Disease at the regional office of the WHO in Europe, does not have a lot of time. So I really want to present the floor to Dr. Bival to really present an update on the status of the epidemic in the region and also the status of prevention. So with that, I'm going to hand off to Stella, and then after which my co-chair will introduce herself and the other speakers. Thanks very much.
Hello, everyone. Thank you for the invitation, and I'm very happy to be presenting today at this meeting, especially after the in-person conference we had last year. I hope you can see my slides. Can you?
Yes.
Confirm? Okay, great. So I will briefly go through the status of the HIV epidemic based on our latest data, a bit on the priority actions of the regional action plans, and a bit of status on some of the prevention measures. So just to say that as we look at the communicable diseases, the highest burden is with hepatitis B and C and many more STIs. And now the latest actually data is that 3 million people live with HIV in the region. But let's not forget that even if the numbers are much smaller for TB, we are home for almost 50% of the burden for XDR-TB, and we are seeing still a lot of TB-HIV co-infections. When we talk about the current state of the HIV epidemic across the WHO European region, which it covers 53 member states, we are completely off track. And you can see that we had 2020 targets to decrease by significant percentages, and we are seeing an increase in both infections and deaths. And,
Stella, can you hear us? The interpreter is asking you if you could please speak a bit slower. Thank you.
Slower. Okay. Okay. Sure. So at the same time, we are seeing the modeled estimates showing an increase, but what the region reports on, the HIV diagnosis, are showing a decrease in the region, across the region, the WHO European region, with a significantly higher decrease in the east side of the region compared to the west and center, where we can see actually an increase in the diagnosed cases. This creates this increasing gap between the estimates and the diagnosis. So it's not actually a good trend to see reported cases going down. That shows that much more needs to be done to close the gap. Although we have been focusing on that, we are not getting there across the region, and it's not an uneven distribution of being off track. On the eastern side, this is happening more, and there's closer to the targets in the west and the central parts of the region. If to say about the transmission mode, what we are seeing is across the years continuous prevalent mode of heterosexual transmission, with 21 being the outlying year. But we also know that the reported mode of transmission and the actual mode of transmission may be different, and the data that we get from the program reviews we had in this year shows that there may be a large proportion of misclassification, and we are working to improve the reported modes of transmission to change that in the next years. Late diagnosis remains a challenge with variation across transmission mode and age. We are seeing more advanced disease diagnosis in males and heterosexual men and women, and in older age groups. And this does not change across the region, across the sub-regions in the region. So testing and treatment cascade, again, we are doing better on the second and third 95, especially on the third 95, but we are completely off track for the first 95 across the region 72. But obviously you can see the difference of Western Europe being close to 95 and the Eastern side 62% knowing their HIV status. TB HIV, just to say that we are seeing a worsening of TB HIV outcomes in the past years after COVID, and this also relates to increased number of deaths and increased late detection. So the treatment outcomes for TB HIV are also worse than before. Now moving to PrEP implementation, the data is collected by our partners, the CDC, through Dublin Declaration monitoring, and you have probably seen this before, but again, the PrEP rollout or introduction is not even. This is the data for 2023. Not all countries have formally implemented in Southeast Europe and even EU, but also in the Caucasus and Central Asia, and some few other countries lag behind. The difference in coverage is very different from country to country. These numbers have probably changed significantly in 2023, and we will look at those in the next reporting, because some of the countries, even in the East, they have started scale up and introducing and scale up quite fast in the past year. If to talk about the other effective intervention, opioid agonist methadone treatment, maintenance therapy for people who inject drugs across the globe, that's the distribution. However, the coverage across the globe is about 18% of the 100 people who inject drugs. In our region, based on the data from European Harm Reduction Association, the coverage is also very uneven. We are not seeing countries increasing coverage in those who have been not doing well in the previous years, and some countries still have laws that are, do not allow introduction of the programs such as Russia, Turkmenistan, and Uzbekistan. Obviously, being so off track and experiencing new challenges in terms of disruptions and increasing divide over evidence-based approaches to prevention, we have to ask ourselves what are the opportunities, and the opportunities are a few. First, at the political level, the fact that new regional action plans have been adopted by the member states, and there's also sub-regional approaches like the Central Asia Roadmap. The accession countries to EU, this brings new opportunities to renew the focus on SDGs and achieving the HIV goals. There's also a lot of innovation that happened in both technologies and service delivery approaches, and we put a lot of hope on not forgetting the U equals U, and the fact that the WHO has released the policy brief on the role of viral suppression in improving individual health and reducing transmission in 2022. That provides clear evidence again, and also a nuanced approach that creates more positive outlook on both decreasing the repressive laws and also making providers sure that and patients sure that when they reach the viral suppression, that actually not only prolongs lives and improves quality of life, but also reduces transmission. On the regional action plans, a few things under the preventing the HIV transmission with particular focus on key populations are the focus on comprehensive prevention programs for key populations, including the sexual health programs, condom, lubricant, harm reduction, and treatment. And also important focus on PrEP, expanding the delivery of PrEP in a broader range of settings, demedicalizing it, including in community-based environments through primary health care, pharmacies, or online provision, and also the fast-track approach. And then I will not go through the indicators and baselines. I will just say a few words on the WHO Euro support to prevention-related programs in 2023. I think this was an important year of increasing the focus on the HIV in the region, both at the regional level. We had a number of important regional events on disseminating the guidelines, the WHO guidelines for high priority countries, and two other joint meeting with the CDC, and also an important event on high level meeting on HIV and human rights, zero stigma declaration, and this was due to EU political leadership as the EU president, holding the EU presidency and putting stigma high on the EU agenda. There was also recently a sub-regional consultation on scaling up PrEP in key populations in Central Asia, together with our partners in ECOM. And there's a number of other entry points for us where we raise the prevention agenda as part of the program reviews together with our collaborating centers. External reviews, technical support to PrEP scale up, and by working on the guidelines and protocols. And since it wasn't so long ago that we had the World AIDS Day, I'll finish with this quote from our regional director of making the emphasis on improving the first 95, but also decreasing stigma as the key priorities of our efforts, and doing this together with communities. Thank you so much, and I'll be happy to respond to questions. Unfortunately, I'm not able to stay further for the session, but you have my email, and I'll be happy to respond. Thank you so much.
Yes, thank you to Stella for this very important update. And as we saw, at least in terms of PrEP, there's still lots of things should be done in the region and beyond. So thank you, Stella, again. And yeah, your presentation will be available in the recording published in the EECA INTERACT website. So your email can be found there. So if somebody of our listeners would like to ask a question, so feel free to look at the last slide and Stella's email and write here. Thank you so much. Yeah, my name is Anda Turtane, and I'm from Latvia. I'm the associate professor in epidemiology in Riga Stradiņš University, and I'm I have a really great pleasure to introduce the next part of our second session on PrEP. So in the second part would be a panel discussion. And we are having two great panelists from Ukraine and Moldova. So from Ukraine, we are having Andriy Bogoslavets from PrEP.com UA and Alliance.global. And from Moldova, we are having Vyacheslav Mular from LGBT Health and Gender.com. So, and actually my questions to you are, what are the success stories or situation in your countries, if we are speaking about PrEP? And what are the challenges? So what is still not in place in your countries? Because, yeah, as you saw in Latvia, even though we are in European Union, we are one of the rare countries not introduced PrEP yet. So currently, thanks to Elton John's foundation, we are running a pilot project. Yeah, but the PrEP is not in place. So what is the situation in your countries? Please, Andriy. Yeah, we could start with you, and then Vyacheslav, you will have the floor after.
Thank you, Anda. Hello, everyone. My name is Andy Bogoslavets. I represent Alliance Global Public Organization. We work in Ukraine, and I will tell you a short story how we start. In 2017, we start with a pilot project for MSM. We had 100 courses for MSM and transgender people in Kiev, and we start to provide PrEP in collaboration with our donor, Alliance for Public Health, CDC, and also clinical health facility number 5. So we start to provide PrEP pills and also analysis test in our community-based organization. So because it was pilot project, and that's why we had to know how it will be work, how people will be react, and how they will be to take a feedback from them. So the PrEP they receive in our office. It was 1 year program, and after this just 1 year program, the national program come in 2019. Sorry, I tell that we start in 2017, but actually we start in 2018. Yeah, and in 2019 we start a national program, and our organization start to implement this program in biggest cities where the MSM is. It is the capital, Kiev, and Chernihiv, and Dnipro, and later Kharkiv, and also 2 small cities in Kiev region, which have name Bucha and Irpin. And we provide this, it's 2 biggest small city in Kiev region near Kiev. So there is a big amount of MSM both. So we start to provide our services. In national program we work in collaboration with clinical, because the amount of clients was higher, and clients start to receive the pills in the clinic. They receive a consultation for our consultants and social worker in our office, and pills from doctors in clinic. And every year we have highest number of PrEP courses for MSM until 2022, when the big war began. And then in February, March, we understand that all of our cities was under combat zone or near combat zone, and we contact to Hornet application. Maybe you know, this is a special application for MSM, which using this for data. They know the data where the migration was. So from the moment of April 2022, we get the information where the MSM has been transferred, migrated, and we start to work also in western part of Ukraine, like Lviv, Ivano-Frankivsk, Chernivtsi, and Uzhhorod. And actually right now in 2023 and 2024, we continue work in this region. And also from June of 2023, we renew our work and start again to work in Kiev region, in Kiev, in Dnipro, and Kharkiv. The only one city where we still doesn't work, it's Chernihiv. And also I would like to tell you that the success story is because the community-based organization is participate, and community-based persons, the social worker, can provide this consultation to MSMs. And also we have informational campaign, we call it prep.com.ua. We have information on our website, and also we have a registration form, which where the MSM client can see our advertisement. Then they come to our website and they can put the application to one of our social worker in the region. and then the social worker received this application. We also use new technology like TikTok, and we use video social network to promote our services. And this is a very big part of the success stories. It have to be services, and also it have to be an information campaign which will be explain about these services. And also we use this video social network because we can say that society, the people come to video social network and they use it. So the information which we post there can be seen by them, and this is like a unique instrument to promote your services. If you speak about the barriers in 2023, this barrier is mobilization, because we work with MSM K population group, and all of them is men, and like other men, they can get a ticket. So some of them are scared, and this is like we see a new barrier for us. Thank you for your attention. This is my short speak to you.
Yeah, thank you very much. So yeah, now the question on the challenges sounds a little bit silly to me. Yeah, sorry for asking that. Yeah, but yeah, the challenges due to the war, they are very clear. But do I understand right that you think that one of the success stories, or one important thing we should do, for example, in Latvia, if we want to promote the PrEP, is this, let's say, communication with the community through social networks, right?
Yeah. And for example, we have, if you give me a moment, we have a few accounts in our organization, Alliance Global, where we have a prevention talks, you can call it exactly. We invite porn stars or community leaders, community opinions leader. And we talk about HIV. We talk about PrEP. Some of the videos have 5.6 million views. You can see this is one of our account, and this is for example, opinion leader about who is explaining to young people about this woman. I mean, about sexual education. And the man near this woman is our star, the part of our project. Leonid, he's like a presenter who is work for us and present videos, and we have a lot of different video. The HIV positive people who is explain about how it's to be HIV positive and why you need to use PrEP to be protected. So the main part and the biggest part is to be viewed by people to have possibility to explain to them about HIV and PrEP. You can see we have a lot of this video.
Yeah.
This is one of our network, TikTok, and the amount of people who view it is.
Yeah. So the really impressive work. Thank you for that. And my greatest gratitude and yeah, my greatest surprise really that you can continue all this work despite the situation, right? So really congratulations to you. And now the floor we are giving to Moldova. Vyacheslav, so what are your success stories and challenges?
Thank you, and Stefan, for presenting myself, and thank you to organizer for inviting me to the scientific workshop to share our experience of PrEP in Moldova. And thank you to our Ukrainian colleagues for being champions and bringing innovations regarding PrEP or other HIV services in the region, and after sharing experience with us. Moldova, I think, is champion in having its national clinical protocol on PrEP in 2018. We were champions in this, but in that year, only 2 persons were on PrEP, and it's available for everybody who needs. After many discussions to think how to improve the situation, after many dialogues, after study visits, we were able to have 3 kind of mechanism of PrEP implementation. It's medicalized one, it's community-based, and it's a mixed one. So Moldova again is champion in community-based PrEP. We started to deliver all PrEP services starting from counseling, hepatitis B, C, and creatinine test. And even the infectionists were coming to our organization to prescribe PrEP and give PrEP to the beneficiaries. But from 464 persons on PrEP in Moldova, 401 persons are among community PrEP, among by our organization, by gender. This number is still small, and under your question to Andrei was right, because when we started with general info campaign on PrEP, and was not so successful, for example, for LGBTQI community, and that's why later one of our barrier that it's a targeted info campaign. So even if we are leading with PrEP services among community PrEP, but we decided to study what are the barriers. So thanks to the EECOM, support of the EECOM, we conducted a CLM community-led monitoring among MSM and transgender beneficiaries of the organization of Gender.com for atom PrEP. And the main barriers were ID documentations presenting when you want to be on PrEP. The second one was creatinine test is not done in the same office because it's blood test, but from bin. It's a clinical near our office, 200 meters far from our office. It's a timetable of the office, and also it's info campaign, targeted one. Our recommendations were like to introduce anonymous PrEP, to revise the national clinical protocol on PrEP, because one time it was revised and it was introduced community PrEP there. But now we want to revise and to put the recommendation of WHO in a revised protocol. We want to change the mechanism of creatinine test, maybe to be more rapid, or to take the recommendations from WHO. Simplification of medicament delivery, extension of staff, timetable, and targeted info campaign. Already we were presenting these CLM results we presented, and we have discussions with National HIV Program, and we agreed that in starting with 2024, we'll change the community PrEP service, first like with disposition of Ministry of Health, and also in 2000, and we'll start to do anonymous PrEP and other recommendations that can be done. And also in 2024, we'll revise the national clinical protocol on PrEP, and will introduce all these mechanisms and recommendations in the protocol. So these are my short presentation or experience, but if you have questions, I'll be great to answer.
Apologies for interruption. Actually, you are breaking a little bit. Would it be possible for you to turn off your video so we can hear you better?
Yeah, it was. There was a short time when we heard you badly, because I think of the internet connection. Now it is fine, but yeah, probably for the safety reasons, maybe you can switch off the camera, and then we could hear you better. So dear guests, dear listeners, so if you are having questions, so please put them in the chat. I would like to ask the question, did I understood correctly that the PrEP program in Moldova, it is covered or paid by the government? But does it start similarly as we heard from Ukraine with NGO initiative, or what was the start in terms of financing, and what is the situation in terms of financing now?
The start in Moldova was like from the state structure, it was medicalized. It was free of charge, but only 2 persons were on PrEP, and was it's for everybody who needs. And after many discussions came community PrEP, and more people now on community PrEP. It's over 86% in community PrEP. And now it's still free of charge. It means like medicine and tests from the state, but community work and other services are funded from Global Fund.
Okay. So the
This is
combination.
thanks to, but this
Yeah.
is thanks to your NAIDS Moldova initiative. Thanks to their study visit and to their support, we started piloting our community prep, and we are champion in the region. And now they see that community prep is more effective, and we want to simplify the mechanism of prescriptions of prep, anonymous prep, and other elements to make more simply be accessible.
Yeah, that sounds a really comprehensive program to me. Yeah, and you're I'm sure that you are providing also different regimes, means the medications that are used permanently and also on off. Yeah,
Yes,
perfect.
we have two regimens. We have on demand or occasion, and we have permanent. For transgender people, also the doctor will decide to get it's permanently. For female, also we have for female in our organization, for female, because it's available for everybody, and it's permanently. For MSM, they can choose permanent or on demand or on occasion.
Yeah, so this was my next question. So you are providing, mainly the service for MSM and for transgender people, but are there we know from the scientific literature that there are also data that's also, let's say, injecting people who inject drugs can benefit from PrEP. Has your country had discussions regarding other groups besides transgender people and MSM?
Yes, the PrEP in Moldova is available for everybody, as I mentioned before.
Okay.
But as I remember, the moment around 30 female or 30, 40 females from them are also sex workers. And I think only a few from injecting drug users, not so many, but only a few. Now we are discussing to expand these services and to make it available community prep, not only in Gender Doc, but also in other organizations, to make the mixed prep, to make it community prep, and to simplify all procedures.
Yeah, no, I think from Latvia, we need to go to Moldova for experience exchange and learn from your best practice, because yeah, this sounds very, very good to me. I don't see the questions.
What I wanted to mention, what Ukraine was good in this, we were not so good in information, because they say that they have information on TikTok, in Hornet, another app. Moldova had a lot of this info campaign and targeted one. So that's why we have until now only 400 people on community prep. But now we're starting to develop these targeted info campaigns.
So, and this
is very important.
Yeah, so and the active information and reaching out through social networks. So this is one really best practice we can learn from Ukraine. So thank you, both of you. I don't see the questions in the chat. I see that there are some comments that currently Alliance Global, with the support of the Public Health Center of the Ministry of Health of Ukraine, PEPFAR and the Alliance for Public Health has launched a pilot intervention to provide injectable PrEP to 100 MSMs in Kiev and Lviv. So this is the message from Ukraine. Yeah, and as part, yeah.
Yeah, this is my colleague Andrei Chernyshev, and he would like to note that our organization is participate in a national program where a lot of donors and it is noted that it's PEPFAR, CDC, Public Health Center, Alliance for Public Health, and we all right now have big national pilot of implementation injectable PrEP. Yeah, in Kiev, Lviv.
Yeah, thank you for this additional information for, especially regarding the injectable PrEP. And yeah, it sounds very impressive to me. Thank you. And now I'm giving the floor to my co-chair, Stefan Baral, for finishing or closing this session. Steph, the floor is yours.
Thank you so much. Thank you. Yeah, I think just a really fascinating discussion. I think there's going to be this big change in PrEP. First, just the sort of inclusion of PrEP as a core strategy, but then the sort of move of integrating long-acting injectable and how complicated it is going to be to do that. With the recognition always to talk that with long-acting injectable, it stays in the body for almost a year, and 9 months of that is at a subclinical level. And so it really is going to introduce a lot of excitement, but a lot of complexity in terms of making sure we do this thing of what we say is covering the tail, in the sense of having people on daily oral PrEP if they come off. And so just in terms of protecting our supply of integrase inhibitors, particularly with this move, as we heard earlier, about towards the use of dolutegravir as a treatment strategy. So just to say, I think there's going to be this really exciting and important shift in this next 1 to 2 years, and that we'll have to manage very closely as a global community. And I look forward to hearing next year when we get together about how that pilot is going, particularly this idea about follow-up. Again, because even though it's less follow-up, you still really need to get folks. With that, I just wanted to thank again such an exciting set of speakers and my co-chair. And I'm going to hand off to the third session to Vera and Kate, Dr. Hankins, to present in. And so I know we're a little bit late, but not much. So thanks very much, and off to you.
Thank you, and Stefan. What a great session. It was really interesting to hear about the use of social media and community PrEP. There are innovations happening across the region that we need to share. It's great to see so many familiar faces and new faces here today. Our final session is going to focus on the invisible or visible community, HIV and health disparities among men who have sex with men and trans people in Eastern Europe and Central Asia. We'll have 2 speakers joining us from the Eurasian Coalition on Health, Rights, Gender and Sexual Diversity, EECA, Nikolai Lunenchov and Nadira Masyumova. I apologize if I've mispronounced your names. Their talks will be followed by a Q&A session. Please submit your questions in the chat box and we'll come back to them in a little bit. It's now my pleasure to invite our first speaker, Nikolai Lunchenkov, who will speak on sex, drugs, and HIV, results of the cross-sectional study in 4 countries of Eastern Europe and Central Asia. Nikolai, the floor is yours.
Hello, thank you so much, and I apologize for the technical issue. I need to share my slides, and I think it should be done right now. So I will talk about the study that we conducted in Kazakhstan. Hold on, sorry, I'm trying to share.
Maybe I can start and then Nikolai will continue.
Do you have slides?
Yes, I do.
Okay, maybe that's a good idea. Why don't you start, Nadira?
Okay. So I shared my slides. You can see them, right? Now you can see it.
Great, perfect. Thank you.
Yeah, so I will speak in Russian, but the slides are in English. Мы в ЕКОМе провели анализ в правовых барьерах в 12 странах и выявили несколько основных трендов. Первый тренд – это то, что национальные государства до сих пор не делают достаточно для того, чтобы работать с ВИЧ и зависят от международного финансирования. Второй тренд заключается в том, что есть очень много барьеров в законодательстве, либо законодательство старое и необходимо обновление для того, чтобы ЛГБТ-люди могли в полной мере реализовывать свои права. Третий тренд – это то, что влияние COVID повлиял на уязвимость ЛГБТ-людей в доступе к здоровью, возможностям трудоустроиться И был очень большой всплеск домашнего насилия, и, к сожалению, в странах делали недостаточно для того, чтобы ЛГБТ-люди могли защититься от него. Дальше это отношение в обществе. К сожалению, оно характеризуется с высоким уровнем гомофобии и трансфобии, и вместе с барьерами по правам человека ЛГБТ-люди исключены из общественной жизни. До сих пор в 2 странах есть наказание за добровольные сексуальные отношения между взрослыми мужчинами. И это влияет на то, что в этих странах невозможно создавать ЛГБТ-организации и пытаться каким-либо образом защитить себя от нападений гомофобов, правоохранительных органов и так далее. И последний тренд — это то, что разница между странами становится все более ощутимее. Мы видим страны, которые достигают определенного прогресса, и заметен определенный регресс в других странах региона. Если нужно было бы обозначить топ-3 страны худших для ЛГБТ-людей, то первое место бы, наверное, занял Туркменистан. Абсолютно закрытая страна, до сих пор криминализированы однополые отношения, нет возможности менять гендерный маркер транслюдям. Следом у нас идет Узбекистан, также криминализированы однополые сексуальные отношения. ЕКОМ документирует кейсы насилия в стране, и мы видим, что до сих пор очень активно используется эта статья. К примеру, в этом году Узбекистан отчитывался в рамках универсально-периодического обзора, и делегаты из страны заявили, что в этом году 23 кейса были рассмотрены по статье за гомосексуальность, и более 27 человек были арестованы. То есть это те данные, которые предоставляют само государство. Еще важный тренд — это то, что если человека обвиняют по этой статье, его тестируют на ВИЧ, и если у него есть ВИЧ, ему добавляют статью за распространение ВИЧ. Неважно, есть ли человек, который получил ВИЧ или нет. И последняя страна — это Россия. К сожалению, очень много было изменений в этом году в законодательстве. Первое — это закон об ЛГБТ-пропаганде. Ранее он распространялся только на детей, сейчас и на взрослых, и уже активно используют эту статью. Затем отменили право транслюдям менять гендерный маркер. И последнее, совсем недавнее, это ЛГБТ объявлены экстремистским движением. Очень важно отметить в анализе это право на мирные собрания и свободу ассоциаций. В 4 странах региона люди не обязаны предупреждать власти о проведении мероприятий, но мы видим, что все равно есть определенные нарушения. К примеру, в Кыргызстане организации могут проводить мирные собрания без уведомлений, но уже год действуют запреты, которые регулярно выходят на проведение мирных собраний. Мы видим, как активистов сажают просто за призывы прийти на мирное собрание. Кроме этого, у нас есть еще риски в Кыргызстане связаны с тем, что был инициирован закон об иностранных агентах, который прошел в первом чтении и где есть уголовная ответственность до 10 лет. Если закон примут, то мы понимаем, что ЛГБТ-организации будут первыми, которые попадут под раздачу. Законы об ЛГБТ-пропаганде есть в нескольких странах: Туркменистан, Россия, и в 2023 году был изменен закон в Кыргызстане о защите детей от вредоносной информации, куда также включили ЛГБТ-пропаганду. Есть непрямые запреты ЛГБТ-пропаганды, то есть их нет в законодательстве, но мы видим практику, которая используется. Это Узбекистан. У нас был кейс, когда 2 девушки поцеловались во время рекламной кампании, и их затем оштрафовали. Казахстан, где в прошлом году запретили показ мультфильма из-за того, что там была сцена поцелуя и так далее. То есть как бы в некоторых странах нет законов, но все-таки есть определенная практика. И последнее — это права транслюдей. Мы видим, что есть большой регресс в отношении, в первую очередь, это право на изменение гендерного маркера в документах. В России было отменено это право в этом году, в Кыргызстане было отменено в 2020 году, и сейчас транслюди не могут менять гендерный маркер. В некоторых странах до сих пор требуется стерилизация, к примеру, в Казахстане. Люди обязаны пройти эту процедуру, прежде чем смогут поменять документы. В большинстве стран до сих пор требуется постановка диагноза, хотя уже МКБ-11 обновленный не имплементирован еще в странах, но не требует подобного диагноза. И основные проблемы, которые мы видим, это усиление антигендерных движений в регионе. ЛГБТ-люди используются политическими силами, особенно во время государства наши, когда пытаются поменять конституцию, какие-то законодательные акты, они используют обязательно ЛГБТ для того, чтобы отвлечь внимание от других репрессивных норм, которые они пытаются привнести в нашу жизнь. И очень мало законодательных норм, которые защищают ЛГБТ-людей. К примеру, антидискриминационные законодательства есть в 4 странах. Это Таджикистан, Украина, Грузия, Молдова. Но только в 2 из них упоминается сексуальная ориентация и гендерная идентичность как защищаемые характеристики. Что необходимо делать? В первую очередь, это это продвижение legal gender recognition, как на русский. Это чтобы транслюди могли менять свои документы. И здесь много, на самом деле, проблем. Если транслюди не могут менять документы, то во всех сферах они сталкиваются с дискриминацией, и они не могут в полной мере реализовывать свое право на здоровье. Или, к примеру, в Узбекистане, где есть статья за гомосексуальность, но в то же время транс-женщины из-за того, что они не могут менять гендерный маркер, они тоже становятся, их тоже сажают по этой статье как мужчин. Дальше антидискриминационное законодательство необходимо. Нужно также работать над декриминализацией как гомосексуальности, так и продвижения информации о ЛГБТ-людях. Интерсекциональный подход, то есть было выявлено, что чем больше идентичности у человека, тем больше шансов, что будут использовать их против них. То есть транс-женщины, секс-работницы, их часто привлекают за секс-работу, но там специально на них выходят из-за трансфобии в некоторых странах. И, конечно же, важно привлекать сообщество. Это все. Спасибо.
Thank you so much, Nadira. This is really interesting, a comparative analysis of the legal environment. Oh, sorry, I'm being translated, but I'll just I got confused there. It's really interesting to do a comparative analysis like this of the legal environments and the rights violations. And to your solutions list, we can maybe add an idea that Anda introduced earlier, which is the possibility of site visits to learn lessons and try to figure out what can be done in the countries that need to move forward. I'd like to now introduce my co-chair, Vera Lyenkova from UNAIDS. And Vera, could you now go back and introduce Nikolai?
Yes, sure. Thank you, Kate. Thank you, colleagues. It's really great to be here. And now we will give the floor to Nikolai Lunchenkov with his presentation about sex, drugs, and HIV. This is the results of the cross-sectional study in 4 countries of the Eastern Europe and Central Asia. Nikolai, the floor is yours, please.
Hi, thank you so much, and apologies again for the technical issue that I had before. So thanks, Nadira, for taking over and covering me once again. We have a last-minute change with the presentation, and I decided to show you the very fresh, very preliminary data that we collected during the study on chemsex in Kazakhstan, which was again very fresh, very new data. So which is a part of my doctoral thesis, and I share my screen to show you the few slides which I made specifically for today. So again, I will talk about the preliminary results of the qualitative study of motivation and risk perception regarding the chemsex in Kazakhstan. And for the background, as you already know, this is one of the biggest countries in Eastern Europe and Central Asia region. Approximately 35,000 people living with HIV in this country, according to the data from UNAIDS. The prevalence of HIV varies among gay and bisexual MSM, ranges from 6.2 to 20%, depends on the report and the study conducted. And the data regarding the substance use among GBMSM is also very interesting. Approximately 60% of GBMSM smoked ever weed, and from 20 and 11% reported using stimulants in club drugs. However, the information regarding the drug use among gay and bisexual MSM is very limited. And regarding chemsex, it's a very relatively new trend that has been observed within the community over the past few years. And almost no research has been conducted on chemsex in this country. So just for the background, the research project is continuation of community-based and community-driven work in Kazakhstan with our partners from community-based organizations. Over the past few years, EECA has established an educational materials and technical support for NGOs and facilitated knowledge sharing. On the screen, you can see the technical guidance, what that was developed for community-based organizations, how to address chemsex support services for GBMSM. So very few slides for the theoretical background before we dive into the studies and results. The core idea of the theoretical framework is the minority stress theory that suggests that multiple stress occurs due to minority status. Minority stress theory proposed three processes through which stressors affect health, behavior, and outcomes, and those are environmental stressors, distal minority stressors, and proximal minority stressors. And of course, I always say that clients never come to our services saying, I'm sorry, I have minority stress, could you help me? Clients usually come with the request, I'm lonely, I don't feel good, I'm damaged, I'm not normal, and so on and so forth. So this is the constant stress that our participants experience due to the stigmatization and discrimination due to the minority status coming both from the outside and from the inside. And when we're talking about chemsex and specific drugs, it's very interesting to mention that there are three classical substances that we consider, which the first is methadone or meal. The second one is GHB, GBL or G. And the third one is crystal methamphetamine or TINA. Interesting enough that for Eastern Europe, Central Asia, and specifically for Kazakhstan, we could add the fourth substance, which is alpha PHP, or as people call it, speed in this country. And the most popular drug is methadone, following by alpha, and almost nobody does crystal compared with Western Europe and Western Europe. So understanding the determinants of specific health-related behaviors is critical for successful health promotion intervention, and that's why we kept in mind behavior change wheel to understand how the data that we will collect during this study can be used to create specific policies. And applying this framework for chemsex is extremely important to know availability of drugs, which drugs are available in this country. As I said, you see already the difference. Where people gather, which premises, which locations, and access to technologies and that enable social connections, which apps, which social channels, and so on and so forth. All this information is necessary to establish successful prevention programs, and I will talk about this at the end of my presentation. So our study had three main objectives. The first one is understand the experience of GBMSM in Almaty who practice chemsex, understand the psychological, social, and interpersonal factors associated with chemsex, and then, which is more important for me as a person working in the public health area, understand what specific clinical and psychotherapeutic services GBMSM perceive and consider the most important and needed. Regarding the methods, we conducted in deep interview, like a qualitative interview. Overall, we collected 21 interview. Each interview lasted approximately 1 hour and was recorded for verbatim transcription. So all participants were recruited through community-based organizations working with GBMSM or in the field of HIV. And we used inductive approach of reflexive thematic analysis to analyze the transcripts, keeping in mind the behavioral change wheel that I spoke before. So results were quite interesting for us. So we are very preliminary, I have to say. Right now it's more than 5, it's around 10 interviews. We finished the analysis. And we divide our codes into 2 main domains, motivation and risk perception. First, we wanted to understand what drives people, why people practice this behavior, and do they understand the risks? And based on the codes you can see on the top of the slide, that this is like explanations what people said regarding their behavior. So of course, one of the main reasons was to experience intense sexual experience. Of course, some of our participants talked a lot about calmness, peer motivation or peer pressure, and surprisingly for all of us, they all clearly understood potential risks that follow with this behavior regarding physical, mental health, violent victimization, and so on and so forth. Let's have a look at the more precise results. We divide motivation into 3 main parts: psychological, social, and sexual motivation. Regarding psychological motivation, people talk about liberation, relaxation, confidence, and calmness. Social motivation, a partner, peer pressure, and communication. So some of the participants mentioned that they do drugs and they practice chemsex not because they desire to do themselves, but because of their sexual partner or their boyfriend do this. And sexual motivation, intense experience, great sex, which is absolutely true, and intimacy that they were seeking for. And for the risk perception, we divide into 4 main parts: mental health, physical health, sexual health, and violent victimization. And interesting enough for us was that despite the very clear understanding of what could follow or what kind of risk due to the criminalization of substance use and high homophobia, people would still follow the benefits of chemsex that can be perceived for them. And again, it goes back to the conversation how we can manage to build a healthy environment for people who practice certain behavior without putting their health in danger. So next steps of our study would be to continue analysis and generate potential themes. And based on the findings, develop an educational model for community-based organizations and medical practitioners in Kazakhstan, and advocate for support and integration of sex-specific services into the standard package of health services for GBMSM. This study was conducted together with the Republican Scientific and Practical Center for Mental Health Almaty and NGOs. I would like to highlight that this study wouldn't be possible without people who work on the ground, those specifically for NGO community friends who helped us with the data collection and who demonstrated the absolutely fantastic support for the community and clearly understood how this piece of research is important for the future of their community. Thank you so much, and I'll stop here.
Thank you very much, Nikolai, for this very interesting presentation. Indeed, it is very important to understand the reasons behind the certain people behavior, what motivates people, whether they recognize the risks, because it will allow us to make informed decisions about how to deal with it. And we are looking forward to read your final results, and good luck with your theses. And I do not see the questions in the chat, and I would like to ask a question to Nadira about the solution you suggested in your presentation. So what we are seeing now in the region is a resurgence of undemocratic and repressive laws and policies in some Eastern Europe and Central Asia countries, which result in shrinking space for civil society and limiting significantly the community-led response, which was already restricted basically in many countries in the region. Yet one of the solutions in your presentation is using the community-led approach. Would you please give us a more details, like a hint, what do you mean? So what would you plan? So not to say that we admire your bravery and strength and resilience, still trying to do something in such a difficult circumstances and context. So what would be your suggestion for communities in other countries in the region? So how to deal with this? Thank you.
Мгм. Спасибо большое за вопрос. То, что мне кажется, почему важно продолжать работать с сообществами, потому что, несмотря на тяжелые условия, во всех странах всегда есть сообщество. И особенно в те моменты, когда государство давит на сообщество и пытается как бы оттолкнуть нас на задний ряд, тем более нужно продолжать работу с сообществами, потому что появляются организации Гонга, которые как бы передают информацию государственным структурам. И мы видим, что такие моменты происходят, к примеру, в странах Центральной Азии. И поэтому важно продолжать работать с сообществом, потому что у сообщества нет доверия к таким организациям. То есть это, допустим, очень странно, когда в стране криминализовано ЛГБТ-сообщество, но, примером, есть какие-то организации, которые могут там работать с ЛГБТ-сообществом. Мы понимаем, что это очень сомнительный, да, шаг. И мне кажется, что в такие моменты важно всегда консультироваться и узнавать у организаций, которые лидируются сообществами, какие методы лучше подходят конкретно им именно в эту ситуацию. Иногда, может быть, лучше предоставить, наверное, ресурсы для того, чтобы организации могли обеспечить себе безопасность или сфокусироваться на ментальном здоровье сообщества. То есть в конкретный момент эти методы могут быть более подходящими, для другой страны другие методы. И то есть, да, и поэтому, да, важно здесь не забывать, что сообщество само лучше знает, что с ними происходит и как им помочь.
Thank you very much, Nadira. It's really very important to apply a differentiated approach as the countries are different and to ensure safety and security for the activists in the countries. So if there is no other comments or questions for the presenters, then I would like to thank all the speakers and the audience for this concluding session. And now it is my pleasure to hand over to the scientific committee of the EECA Interact, Professors Anda Kivite-Urtane and Kate Hankins, for concluding remarks. Dear colleagues, the floor is yours.
Yeah, thank you, Vera. So thank you to all the presenters which provided us with very rich content of this workshop. And thank you to all of you who were listening, but all of this could not happen if we would not have an excellent team. And that's why allow me to use 1 more minute, even though we are having the end of our workshop. But I really sincerely want to thank all our teams working on this workshop. So my sincerest gratitude to Global Health Platform team, to Ellen Roskam, Bettina Zago, Negar Mansouri, Jie Yang, and also to FU International team, Yulia von Polanen, Yulia Como, Yekaterina Nikiforova, Olga Shelebacho, and also the team of the Amsterdam Institute for Global Health and Development. Thank you, Marloes Nichboer. And thank you also to our great interpreters, Tatiana Williamson, Golyandrina, and Natalia Hanegraaff. So thank you for all of my heart. And now, Kate, the floor is yours.
Thank you, Anda. Your feedback is really, really important to us, everyone. So please fill in a short survey about today's workshop via the link in the chat box, and also you can find it on our website. The recording of the event will be available in a couple of days if you want to share with colleagues and friends at the EECA-interact.org website. We're also happy to invite you to our next in-person scientific workshop EECA Interact 2024 will take place in Tbilisi, Georgia. We hope to see you all there, and please enjoy the rest of your day or your evening. Thanks for sharing your time with us. Goodbye, everybody.